Can you hear me? That's good. Okay. Well, Dave has not seen this presentation, but what I'm going to talk about in a bit resonates very much which he just said. To start off, no conflicts of interest, and hopefully I'll weave through so at the end you can understand why I say the content of medicine has changed greatly, the structure of medicine has changed somewhat, and the care of or in medicine has changed little, or should have changed little. Let me see if I've got this. I'm also going to do this in a different manner. So I'm going to talk about healthcare systems, and then I'm going to talk about stories. And they're my stories, because talking about stories is really how we interact as person to person. And you'll have to tell me later whether it worked or not. This is me and my trajectory as a qualitative researcher. You've got to know who you're hearing from to some degree. So at that very top one, this is University of Toronto, so where I came from a different healthcare system, and I also spent 3 months in Great Britain. The next, over there, 1980 to 2005, I get this there. That was a brand new medical school in Northeast Ohio. So as I arrived in Northeast Ohio, because my husband Bill, who's here, took a job there, they looked at me and said, oh, a residency educated physician, we'll get her involved in education. I jumped on board. The gentleman right there is a fellow long gone by the name of Claire Reese, who taught me to be a doctor. There's a difference between teaching the facts of medical education and being taught how to be a doctor by working with him and the practice of his for 30 years. Also during those years, we had 3 children, and at the end of that time, I became the chair of that department. Then, having felt like I'd done what I could do there in that setting, moved to this next setting, 2005, 2008. Does anybody recognize it at all? I don't expect you to. It's Brody School of Medicine at East Carolina University. A very different culture, and I learned very different things. Again, the care of medicine was the same. Then 2008 to the present, I really had no intention of leaving Brody, but Bob, our prior dean, can be a great persuader. And the thought of moving back to the north, to Wisconsin, Bob Golden didn't have to offer too much, in a sense. Because what you may or may not know is that University of Wisconsin is one of the leading departments of family medicine across the country. So that family medicine was only recognized as a specialty in '69. UW had one of the first residency programs and continues to be recognized within the top 10 for family medicine across the country. So this opportunity to go and practice here, that's our department, makes sense. And this is the new building in Belleville where I don't know if I'm getting out of this, where I practiced for the remaining years of my practice from the time I moved here in 2008 till the time I stopped seeing patients in 23. And I learned a lot, and I learned a lot from other people. And I'm going to take this moment, because I'll leave it later, is that One of my teachers here in Wisconsin, Bill Scheibel, is at the back of the room. And Bill is a person who, when I first came, saved me from making some errors, so I thank you for that, Bill. And has always been somebody that many of us could turn to. Now, first story about me. This is Christmas Eve in my internship year. The internship year is a fabulous year. You're learning all the time. It's very exciting. I interned at a hospital in the middle of Toronto. It was very busy. You can imagine Christmas Eve was no exception. It was just cacophony. One of my patients was a lady in her late 60s, came in at the end of the day with her just so weak. Her 2 children had come home to find her so weak she was having trouble walking around. They brought her to the emergency room. Over the subsequent 6 hours, we tried everything. We tried fluids, we tried antibiotics, we tried steroids, we tried pressors, and at that time, that was all we had. And she was dying. There's a moment where we were pulled aside into the dark, into the little quieter space in the emergency room. Her 2 children were across from me. They're my age. Their mother was there. Their father had died that preceding year. And all I could say was, "I'm so sorry." She probably died of overwhelming sepsis. A few hours after she died, Bill came and picked me up when we went to visit my parents and have a normal Christmas. My life continued. Their life will not continue the same way. The lesson for me from that was sometimes all you can do is be there. And there's lots of situations that we can all remember from that. So, at that time, as I said, family medicine, I'm switching back down to the big picture, was developing. There was a number of commissions, there was a need for more primary care, general practitioner type positions, and the sense that the piecemeal, fractured medicine was developing, and that was not satisfying to patients. So the shortage of health care, the desire to have a generalist who takes care from birth to death, what Dave talked about earlier, the sense that we needed to focus more on health and well-being, prevention, salutogenesis, and lots of communication. Moving out of the hospital to where the patients were. So most medical training, it takes place in that very tiny box at the bottom, right? Less than 1% are hospitalized in academic health centers. That's where medicine takes place, our education. But really, health and well-being is in the community. And that was a big change. Oops, no, there. No, now So Barbara Starfield is a health services researcher that did most of the work on primary care and family medicine. And what are the characteristics? So first contact, continuity, comprehensiveness. You can't say I don't do that. If I don't do that, then it's my responsibility to get you to somebody, somewhere, to take care of that. Coordination, we talk about low tech, high touch, and community, which we'll talk about in a minute. Yes. And this is the next story. Community. Sometimes people have it's a difficult concept. What do you mean you're practicing in the community other than having your office there? Well, I have found that your community comes to you. So that when I was in Youngstown early in my career, I was the only female physician doing OB. I did a lot of televising. You filled the need for the community. Another example in the same community was the young man who came home to die. He came home with his partner. They went off. I was asked to provide palliative care, which I was happy to do. And of course, we all realized, but it's unsaid, that he was dying of HIV at that time. And then the knock at the door. The knock at the door, I thought, as it went on, was amazing and couldn't be happening. 2 months into this small college town community, the knock on the door came from a young woman. I didn't recognize her, teenager. I thought she was there to give greetings because it was that kind of very small community. I asked her in. She sat down, and then she started to cry. And some of you may realize what the dialogue's going to go next, where it's going to go. She had a positive pregnancy test. She was the daughter, I found out later, of one of the ministers. She couldn't talk to the physicians in town. She couldn't talk to anybody. She really didn't know who to talk to, except that there was this new person in town that was a physician. Well, talked to her about the medical part. She probably was really pregnant, but this wasn't false. And talked to her about where she could go. At that place, it was the closest was Pittsburgh. She left. I didn't see her again. Socially, I saw her months later. She looked fine. She nodded to me. She said quietly her boyfriend took her to Pittsburgh. I don't know whether she talked to her parents. I encouraged her to do so, but she was certainly resistant at the time. What did I learn? Well, you function to meet the needs of the community, even though they're certainly not what I was expecting at the door. So back to the health system. So increasing primary care is associated with all sorts of good things. And this is Starfield's worth. Lower morbidity, mortality, costs, expenses, with an increase in satisfaction and equity. And if you look at it nationally by countries that focus on primary care versus specialty care, they have all of those same attributes at lower costs. So why don't we expand our primary care? What's happening? We're still having a lot of healthcare system problems. That's our expenditures. This is the U.S. expenditures. So over here was when Eminence came into existence to supposedly help some of this. And we really didn't make much of a dent. And of the 30%, over 30%, by the way, of that increase is in hospital costs. 20% approximately is clinician costs. Of the clinician costs, it certainly is not primary care. The primary care is that little orange top of the bar. The workforce is still needed. 100 million Americans lack access 2 in 5 physicians will retire. A couple of us are here. And the population will age, and as the population ages, the needs are greater. And that's Becker's is a hospital review. That's 25 statistics, 2025. One of the reasons that has persisted is what you can see as a payment gap. So the average cost of medical school in the States now is $238,420 for 4 years. What you get as a salary it's a good living. Nobody's ever going to say that it's not a good living. But that top lines are for radiology and the bottom lines are for primary care. And that includes, when I say primary care, family medicine, general internal medicine, and general pediatrics. Also, we're mal-distributed, so that it's worse in the rural areas. Those are the way that healthcare professional shortages areas are assessed. And as you can see, lots of dark areas. We're actually in Wisconsin better than many. But primary care includes all primary care providers. There are huge areas lacking any provider. And then there is what I call the, oh my goodness, the work of primary care. Primary care patients have an average 3 to 8 problems, 40% multiple comorbidities, and the complexity, if you measure the complexity of going from problem to problem, they have more complex patients than cardiology or psychology or psychiatry. 40% of new presentations never fit any known diagnosis, and 75% of the complaints are self-limited. This is a very different practice than a practice that focuses on a particular biomedical presentation. And it's not a good or a bad. We need both. But this is our world. And I think many studies, there's now 4, have looked at the ability of primary care to incorporate all of the recommendations for prevention and all of the recommendations for chronic care put out by various societies, whether it be the American Diabetic Association or the American Heart Association. And as you can see, it's impossible. It's an impossible task for a primary care physician to attend to all of that. Later on, we'll talk maybe about some solutions. And so then what happens? There's lots of reasons for burnout, physician burnout, and that's across all physicians. The worst group that have the highest levels of burnout are in the ED. Yeah. Has anybody seen Pet here? The series? It's a very beguiling series, I would say, focused on the emergency room set up in Pittsburgh, Pennsylvania. But the sense of having low control about what you can do, always being behind, always trying to catch up, results in emotional exhaustion, depersonalization and cynicism, reduced sense of personal accomplishment. If your doctor feels bad, they're not going to do a good job with the patient. The pandemic, of course, made it worse. Because what happened in the pandemic is what was certainly present before, but there was a loss of trust in healthcare. Violence against healthcare practitioners increased. So that, as you can see, couple of polls range from 15% for all physicians to all clinicians and 55%. The moral injury is really that sense of not being able to do for your patient what you want to do for them. And so it's part of the expectation for constant availability also, which is impossible. So we talked about, I mentioned violence against physicians. Well, the violence against physicians for me was mostly understandable. It was mostly patients who just blew up. And I've never been in a situation where I've had guns pointed at me, but not that I felt really and truly at risk. What I was, and what I'll tell you the story about, is I was pained by the violence that my patients had to deal with. And whether it's because I'm family physician is female, I met a whole lot of domestic violence. I'm going to tell you two quick stories. One is about a regular patient of mine. She came in one day, routine follow-up. She walked into the examining room with sunglasses on. Take her sunglasses off, she has a black eye. To make a long story short, the partner, the fellow she moved in with, was becoming violent. We started to talk about what we could do. Roll ahead, 2 weeks later, her partner shows up as a new patient to me. Comes into the office, and there was an area like this. Takes the gun out of his holster, puts it down with a bang there, looking straight at me, and says, you know, I want to tell you that my girlfriend, I know you've seen her, she exaggerates all the time. He was a local police officer. This is good news, because I tried to call her back when she didn't come for her next appointment in a few weeks. She's moved. She's found safety. She's gotten out of the community. The other example is perhaps not so great. And this, you know, when you don't have a good outcome, it always sits. I can see this person. A woman about my age at that time, in the 30s, she came in, she was so thin. She looked sallow. She looked sad. I'd never met her. She was a new patient. 3 children, money tight. She wasn't eating much. I really think that part of what was going on with her was poor nutrition. But it took her 3 visits to tell me about the verbal abuse and the controlling behavior of her husband, and how on Sundays she was shared with her brother-in-law. I tried to call her weeks later. The whole family had moved. I don't know what happened to her. Okay. And the EHR, our favorite thing. Nobody would go back to not using an EHR. It's a wonderful tool, but it's a tool, and it's sometimes not used well. I think it's getting better, or I thought it was getting better. But I just came across this, literally, August 25th, 25, upcoming epic changes last week on Becker's. And I thought to myself, oh my goodness. We have a problem. We definitely have a problem. and it's not getting better. And again, are we living better, happier, longer? Well, if you compare us to other developed nations, we're at the bottom for longevity for men, and the second to the bottom for women. And the popular press has really publicized pretty well that our overall life expectancy is decreasing in this country. Decreasing for men and women. We're stuck. You gotta have a little humor with these numbers. So I want to talk about future considerations. More health care, not necessarily care, but carers, teams, technology, politics, social media, challenges, relationship, and community. Very quickly. Actually, if you compare our number of healthcare workers, nurses, and physicians specifically, we have less than many of the other developed countries. We can have more, and I think would be better served. For primary care, the only way we're ever going to get what we should get done for our patients is through teams. Our multi-professional teams, which are still in their infancy, are really needing to be developed. And this is just a schematic of where we'd all like to be, where we have contact with various healthcare professionals, social workers, physical therapists, pharmacists, the whole gamut to serve the patient. This was one of my teams. This is indelible. Okay, and patient wisdom. Patient wisdom is a story about the other member of the team, the patient. And I think we, meaning professionals, tend to forget that, but obviously the most important member of the team is the patient. So, and I chuckled to think of a woman who was pregnant when I was doing a lot of OB, and I was going on an international trip. She said, "I'm going to wait for you to deliver this baby." 3 weeks past her due date, 24 hours after I'd entered the country, she delivered. People know their body. I can't tell you how many, and I don't say this in any kind of disrespectful sense, but it was my patient population, little old women who didn't have optimal blood pressure, but every medicine we tried didn't make them feel well. They didn't like the way they felt on the medication. And having lived through lots of, you ought to have a blood pressure of 130 over 80, or you ought to have a blood pressure of 140 over 90, or you develop a little bit of skepticism. And I think that we are all best served by listening to the patient and what works for them. And then the final example is that closer to home, my brother-in-law. My brother-in-law, 82, fit as a fiddle. Every test imaginable was perfect, but he didn't feel right. He went to see his primary, maybe because he had a friend with this, who knows, he still doesn't know. He said, "I want a PSA testing." That's the test for a prostate cancer, or prostate. And he got it, and it was abnormal. And the biopsy was done, and he had atypical cells. He's now finished his radiation therapy. So over and over and over again, I think you can ask any clinician, Dave, I know, Bill, patients know. And all we're taught. We say this to ourselves again, listen, listen. They're telling you. So, technology. I'm not a person who dismisses technology. I think it has great potential, including AI. The concerns for AI, of course, are the costs, the electricity, water, air pollution. We really don't have a good handle on that. Those costs are increasing. And then we'll talk a little bit more about later about politics, theft, and the potential for AI to be manipulated. And then our own science literacy and the challenge with that. Garbage in, garbage out. We always need to remember. But robotic surgery has been going on for a couple of decades, and it's going on well. The use of AI for diagnosis, EKG, EEG, skin malignancy classification, mammography, chest X-ray abnormalities, all have been consistently excellent. This technology is growing so quickly, it's hard to keep up with it. And I said full references, but then my references got stuck in here, which we're just going to ignore. But anybody who's interested to have them. Now for primary care, I had used in the past a scribe. Now the scribe was a real person on the end of the telephone or whatever was connecting at that time. AI scribes now are being used and being used pretty effectively. I think we're still a ways from having the efficiency we'd like, but the application in spitting out patient and family care tools during the visit so people can get it, interprofessional team tools so people can use that information, and community health tools in the same way is, I think, going to be very helpful. This, not so helpful. This I came along just doing the review for this talk. The commercialization of information and access for patients is increasing, and it's daunting. Patients get the wrong information often, and it's not healthy for them. Then politics, social media, and science literacy. Where's the science? The first cartoon is the politics. Exploding costs, rationing. Nothing in between. And then what we're talking about a lot, especially these days, is the war on science. That actually dates from pre-pandemic, that particular. Okay, and I love this one. There are three kinds of lies. Lies, damned lies, and statistics. From Mark Twain. We have a lot of, in medicine, anywhere, a lot of misunderstanding of those statistics. So that we are people. We operate in the bell curve. This is the way we look at statistics. And there are smokers who never get lung cancer. And there are the person who was immunized for COVID and still got COVID. We need to understand that in general, we don't have that literacy. So just a little bit about COVID. Before leading me in, this is the incidence of COVID, and what I really want you to pay attention to is that the multiple studies vaccination, unvaccinated, and the incidence, meaning vaccinations work. But our population, significant percents of our population, don't believe that. How common are serious reactions to COVID and immunization? That's what they're afraid of. But if you look at this, very low, 1 to 5 cases per million doses, 3 to 5 extra cases per million. Multiple studies or multiple side effects. But it frightens me. And then hospitalization risk by immunization status. So you can be immunized and still get the disease and still end up in a hospital. However, it definitely is less. I want you to look at that immunocompromised adults, 38%. So that's the risk by immunization, the lowest risk. And I'm going to talk about failure. This person I'll call Phyllis. She was my patient for over 10 years. A forthright, unpretentious woman who built her own business, cleaning business. She lived by herself. A prior marriage she dismissed. And maybe I shouldn't have been surprised when the pandemic emerged and she didn't want to get immunized. I do remember her telling me that she'd gone off with her girlfriend to hear Trump in Minneapolis. And there were a lot of deniers. It was the Wednesday before Thanksgiving in 2020 that I got the call from one of my colleagues that had seen her in the office that day and was worried. She was short of breath. She didn't seem to be well. They were going to check on her Friday. Friday, she was so short of breath on the phone that we called the ambulance. She was admitted. She was intubated that night. She hung on for the next 4 weeks, and the week before Christmas, died, alone, sedated, in the intensive care unit. I still think, is there anything I could have done to convince her to get immunized? And it's no guarantee. Mammography recommendations. Another example of things that may or may not be taken to heart. So these have just changed in United States so that you can see the starting age is 40. And then if you go over, if I can get this working, to the United Kingdom, France, Germany, and Canada, the age of 50. Do we have different diseases? I don't think so. We have different policies, public opinion, and healthcare systems. So we want to challenge our thinking in what we call the persistent paradoxes. Behavior change has the greatest decrease in mortality. That is true. So that behavioral patterns influence outcomes strongly. Specialty physicians provide better quality of care for specific diseases. Primary care physicians provide better whole person care. Both are true. mix. Primary care is so complex, no one can do it. Primary care is so simple, anyone can do it. Again, the paradox of our healthcare system. Patients want a continuous healing relationship with primary care physicians. Patients want convenient health care from whoever is available. Both true. Now, another story of books about how to die. As Phil was a patient of mine that I first met when I came to Wisconsin. I went to see his wife on behalf of my colleagues, and there was Phil, an amputee at that time, always with a smile on his face. He ran a motorized scooter all around his house. They were in that same house that they raised 5 children, ran a farm, and he now looked down on the church that he donated land for. An amazing man. I never saw him without a smile on his face. But over the next 6 or 7 years, he lived alone after his wife died that first year, with family support. He had recurrent GI bleeds, severe vascular disease, another stroke, and eventually required amputation of his other leg. Still, he laughed and smiled. He moved to the nursing home. I continued to see him there. He continued to smile and give me a hug every time I saw him. Everyone loves him. However, another stroke left him speechless, but not without his smile. Recurrent pneumonias eventually revealed a mass in his lungs, and the last time I saw him, just before his death, he still tried to smile and give me a hug. I want to live my life like Phil. He was a lesson in how to face adversity. And the mystery, complexity science, is how we try and understand ourselves. Studies systems made of man interacting, interdependent components that self-organize to produce patterns and behaviors not predictable from the components alone. That's us. Trust over time, knowing the parts and the whole, working in partnership. It's the relationship. Illness cannot be understood apart from the person who's experiencing it. I learned that people will forget what you said, people will never forget how you treated, how you made them feel. And the strongest predictor of long-term happiness is our degree of social connection. You're here, you're connected, you're healthy. How to survive a tragedy. 11 a.m. on a Sunday on a country road, a 17-year-old guy. He was racing along with an ATV that a friend of his was riding. The community was devastated. The person on the ATV was devastated. That family, a family of my patients, will never be the same. But I want to tell you, the memorial service for the whole town was one like I've never seen. Everybody was there. Everybody from the communities, the schools, remembering, laughing, having the occasion. Even now there's a scholarship. There's anniversary celebrations. And it is the relationships with those people that will sustain the relationships in that community. This is a very interesting book I highly recommend. Vivek Murthy was the Surgeon General, and he talks about the healing power of human connections. Reminders. Reminders are for me at home as I turn and I see the drawings, the glassware, the crystal goblets, the handmade jewelry. At one time, 11 baby clothes. The sweets, desserts, and the candies over the years. It has been an incredibly rich professional life. It's not what you do, it's who you are with them. Patients have given me grace, taught me humility, respect, generosity of spirit, appreciation of community, forgiveness, and most of all, joy. So I'm sorry I've gone a little bit over, not too much, but thank you for your attention.